Good morning. My name is Caroline Ashton Goff, and I'm the Admiral Nurse Dementia Clinical Nurse Specialist at Princess Alexandra Hospital in Harlow. And I'm really delighted to be here today to present a presentation on recognising and supporting distressed behaviours in dementia on behalf of Dementia UK Summer School 2023. And I will be looking at possible causes of distress behaviour, drawing on my experience within the hospital setting, the acute hospital setting where I've worked now for 33 years, and also my role as a volunteer within the community with our local hospice and volunteering in the coffee morning, dementia coffee morning. I'm also going to draw on experience of the COVID pandemic, and I will be talking about delirium and how that impacts people with dementia, what is meant by meaningful communication, unmet needs, supportive interventions, and lastly, fundamentals of care. So, to start with, I think it's useful to have a definition of what do we mean by distressed behaviour in people with dementia. So, that can include a range of non cognitive symptoms such as apathy, anxiety, depression, agitation, aggression, delusions, and hallucinations. Walking with purpose, incontinence, altered eating habits, sexual disinhibition, shouting, hoarding, repeated questioning, and sleep disturbances. But we must remember it's an active attempt by the person with dementia to express for us to meet or express an unmet physical or psychological need. So, why is this important to consider distress behaviours in hospital? We know, for those of us working in acute care or those of you who've supported people with dementia in acute care, that hospital admissions can be overwhelming for someone with dementia. The person may not fully understand where they are or why they're here, often asking to go home because home is where they feel safe. Hospitals can be loud and unfamiliar environments. And if the person with dementia doesn't receive stimulation and have regular emotional support, this can really impact on their well-being, putting them at really high risk of deconditioning and an increased length of stay. Of course, during that length of stay, there also may be a high incidence of the person with dementia developing delirium. All of this can lead to changes in the person with dementia's behaviour. So, what factors might influence behaviour? It is really important to consider that behaviour is not just always a response to the dementia. It's important to consider all the possible causes, and that may be a way of communicating an unmet need and think about it in terms of biological, psychological, social, and spiritual causes. This often happens due to cognitive changes in the brain, and this will not only affect the person's memory, it will affect their judgment, their orientation, their ability to plan and to process. They might be acutely unwell, so they will be at increased risk of delirium. For our patients with dementia in hospital, that can be up to 25 to 40% of those patients. They might um, present as being restless, agitated, have mood changes, and they may be experiencing hallucinations, and all of this may then lead to them resisting care or what some staff may call challenging behaviour. They may have underlying sensory loss, such as hearing or sight loss. They may not have access to their glasses or hearing aids. They might be hypersensitive to touch. They might have physical needs that are not being met, such as going to the toilet or being hungry or thirsty. And psychologically, some people with dementia might misinterpret what is happening to them. For example, when we are providing fundamental care, for example, hygiene care, they may misinterpret that as being someone trying to harm them. And this may cause them to develop strong negative feelings towards us in response to this, and that may cause them to push us away or hiss out at us, and then that would be called aggression. Socially, they would have had lost their usual social support, particularly in the height of the pandemic when we had restrictions on visiting. But there may be restrictions equally on visiting if they are being isolated for an infection, or it may be if there's a lack of understanding around the importance of visiting in the hospital settings, which is why it's really important for hospitals to be aware of and to sign up for John's campaign to support family carers to visit at any time. The impact of the hospital environment may be particularly noticeable at times during busy times, such as ward rounds, staff handovers, cleaning times, the Hoover. Meal times, trolleys being pushed by, and the noise level can escalate and behaviour may change in response to this. There may be a lack of stimulation, although the environment seems very busy. But for the person with dementia, they may be sitting in their chair, feeling very alone and ignored, and may feel that nobody knows that they are there. Spiritual care for a person with dementia incorporates more than religion. It encompasses culture, beliefs, and a sense of meaning that will be unique to each person, just like you or I. Think of a person who's normally surrounded by their dogs or their cats at home. Think of a person who may normally hear children playing outside if they live next to a school or a playground. A devout Catholic who has dementia separated from their rosary or important objects. Think of a Muslim who has dementia is no longer able to pray. Knowing their life story will really help you to understand the person with dementia and maybe the reasons why the behavior behind the behavior. One of the important things to consider in terms of distress behaviour is the high incidence of delirium and the causes behind the delirium. And Pinch Me is a really useful acronym to really understand what might be happening in terms of understanding the behaviour in somebody with dementia. Pain stands for P stands for pain. Of course, pain could be palliative pain, at the point of diagnosis for the person with dementia's journey, there should be a palliative approach to the person's care. But we know due to evidence in hospital, the research tells us that pain is often misunderstood and not recognised. Pain could be difficult to control post surgery or post anaesthetic, resulting in a higher incidence of delirium. Infection could cause delirium, but also the risks of isolation and the impact that this has on somebody with dementia and the risk of deconditioning. Nutrition is an important consideration. The lack of nutrition, of course, maybe not having access to foods that the person would normally enjoy, or at the times the person would normally eat and drink a main meal. So providing snacks and drinks regularly, but even in between meals, is really important. C stands for constipation, and of course that our patients with dementia are high risk of developing constipation, particularly if we're not encouraging them to walk to the toilet and bringing them a commode instead. So that's really important to keep people up and moving if possible. Dehydration, of course, particularly in advanced dementia, may be really difficult to manage if somebody is not eating and drinking well. But dehydration can cause people to become really dehydrated and cause delirium. Medication, um, polypharmacy, making sure when a person with dementia is admitted to hospital, we look at the medications they're on and we rationalise those, particularly if there's repeated refusals on drug charts, and look at the causes of certain medications and do we need to continue those, and how that may impact on the person's mobility and the increased risk of falls. And the impact of the environment and the over or under stimulus for that person with dementia. Just to talk a little bit more around delirium. So, delirium is really common. As I mentioned earlier, it is a clinical syndrome and it is an acute event. And it's characterized by an acute onset, which can develop over 1 to 2 days. And there'll be a fluctuating course of deterioration in the person's mental function and disturbed levels of consciousness. Now, delirium can happen to any one of us, but when it happens to a person with dementia, we call that delirium superimposed on dementia, and that can have a real impact on their whole self, their physical health, their cognitive health, their ability to eat and drink, their ability to mobilize, to be well, and to have a real sense of well-being. We classify delirium into three different subtypes, and the first being hypoactive, which is often misunderstood for advanced stages of dementia. And hypoactive delirium could present as apathy, sleepiness, and lethargy, and the person may be withdrawn, and staff may just assume that how the person with dementia may be. But sometimes there can be reversible causes, such as having a bladder full of urine or being very constipated. Hyperactive delirium can present in people with being agitated and restless. They may be displaying distressed reactions or maybe aggressive towards staff because they feel they're being harmed or they're being kept in prison. And that can be really distressing for the patient and also very distressing for the families as well to witness. But we can also have a term called mixed delirium, where people fluctuate between the two. But it's really important to remember that delirium superimposed on dementia can come with a 40% chance of mortality in our people with dementia, and that's a really high figure. So having knowledge around delirium for us is important. One of the other causes to consider for changes in behaviour may be the effect of sundowning. Now, there's lots of research around why sundowning occurs, but we know that this is caused by changes in behaviour that happen in the evening. And talking to family carers, they will always recognise this. They will say this happens around 5 p.m. meal times. And symptoms might include a sense that they are in the wrong place. That often, as the day's gone on, the person with dementia may become more tired. They may have been walking around your ward all day and they're becoming very weary. And of course, this leads to their symptoms worsening. And there are lots of reasons why this may occur. And it can lead to frustration because the person with dementia may be less able to communicate their needs or really to be able to express to you what is wrong or actually even to be able to perform simple tasks. One of the things that those of us working in hospitals will recognise is people wanting to leave the ward, people with dementia wanting to leave to go home, maybe to pick children up from school or go home to prepare the husband's evening meal. This is quite a common occurrence. One of the things that is really useful in this situation is particularly is to make sure we have a completed This Is Me tool. This Is Me is a document that was developed by the Alzheimer's Society, and there are various other options that have been developed, particularly there's also one Dementia UK. But This Is Me is what we use in our acute trust here, and it's a document that really will enable us to record the person's usual behaviours, the food and drink that they like, their mobility, their family, who is important to them, what helps when they become distressed, what is their religion or spiritual beliefs, do they like music, and what interventions, supportive interventions they may have at home to support them. Yeah, having a completed This Is Me is like having an insight into the holistic person, and there are many examples of this working really well. But one really important consideration is to allow the patient to walk if it's safe to do so. Don't restrict them, don't keep asking them to go back to their bed. They may be very active people normally, they may walk every day, may walk marathons. So enabling them to walk if it's safe, if that you have a nurse or a volunteer to support them or a family member is really important. If the distress is increasing, it's really important we consider all non-pharmacological approaches first. And by that I mean any supportive interventions we think might help, families, volunteers, distraction, watching TV, just having a walk, being alongside that person, and trying to avoid pharmacological intervention. By pharmacological intervention, we mean the use of medication to help calm, reassure the person. But we know that there comes a high risk of falls in people with dementia, so we try to avoid that if possible. One of the tools that is useful to use in this situation may be the Vera framework. The Vera framework was developed by one of our mental health nurses, actually, from many years ago, called Amanda Blackwell, and one of her colleagues from one of the universities. VERA stands for Validate, Engage, Reassure, and Activity. So I have seen this used in practice, and sometimes it can work. So it means to validate the experience for the person with dementia. If they are saying they want to go to school to pick up their children, validating that as a real experience for them and talk around that topic, ask them about their children. Maybe someone else can pick the children up from school. Maybe if you feel confident, talk about your children. So validate that's a real experience rather than just dismissing that. Engage in the conversation, keep the conversation going and try to keep it positive. R for reassure. Reassure the person with dementia that the children will be safe and that somebody will collect them. And A stands for activity. So trying to find a way to come away from that situation if possible. It sometimes is a really useful tool. So just to continue a little bit more around behaviour and seeing behaviour as meaning. So it's really important that we recognise behaviour as an expression of an unmet need. And the examples on the slide here cover aggression and agitation, restlessness, repetition of sentences and noises, walking or wandering, feeling lost, and becoming withdrawn, becoming more lonely and frightened. And these are the ways that people with dementia might respond to something negative or frustrating or getting more confused in their social or physical environment. It's really important that we consider that all our expressions, gestures, and words that have meaning, and to understand the meaning is to understand and consider the factors that influence the behaviour. If we go back and consider and reflect on the acronym Pinch Me, this is a really useful tool to help us to understand that meaning because that covers the social, physical, environmental aspects. But when we do experience someone exhibiting a behaviour such as these, it's important to reflect on whether this is a challenge for them or for us. What we find may find challenging in our acute environments, can we adapt that so it's not challenging for us, for them, it's challenging for us, and think how we can adapt to that and allow them to do what they would like to do. Thomas Kitwood, Professor Thomas Kitwood, he was the first in his field to look at people diagnosed with dementia and see the diagnosis, see the person beyond the diagnosis. And he authored many texts before his death in 1998. His first book, his influential book, Dementia Reconsidered, The Person Comes First, he argued passionately about a philosophy of care in which the person comes first. And he challenged the notion that dementia leads to the loss of the person who they are. And his flower of psychological need, which you can see on the screen here, really encompasses all of those things that are important to all of us. Just to describe this in terms of people with dementia and what that means to them, we think about the term comfort for those of us with a healthy brain and an active being. We can provide our own comfort. If we're uncomfortable on a chair or in bed, we'll change our position. If we have a headache, we'll get a paracetamol. For our people with dementia, they rely on us to do that for them. They rely on us to be their advocates. And comfort for people with dementia in hospital is really important. Attachment, going back to the previous slide when I spoke about the Vera tool, attachment to our parents at birth is why often people with dementia call out for mum or dad, because maybe mum or dad are the people that made them feel safe. Of course, relationships change over time, but many of us, when we're unwell or we're frightened or lonely, it's mum or dad that we want. So it's thinking around why the person with dementia is calling for mum or dad and how we can support and reassure them and provide that comfort. Think about occupation. Knowing the occupation of the person will really understand how to support their needs. They may have been a ballerina, they may have been a clerical member of staff. May have seen many nurses in practice that have come into hospital, and that will really help you to understand the behaviours they're presenting with on your ward. You think about the term inclusion. For those people with dementia who may not be able to reliably communicate a need, it's still really important to ensure that our housekeepers, our domestic staff are aware to still include them in menu choices and ask them the questions so they feel included. And having an identity, how we would like to have our hair combed, what clothes we would like to wear, would we like a male or female carer, what's our spiritual and religious beliefs are still really important considerations for people with dementia. And all of this, the fundamental roots of all of this, all of the things I have discussed are the fundamentals of care. And what I mean by fundamentals of care draws on the work of Maslow, and fundamental human needs include being able to move, sleep, rest, eat, drink, and interact with others, and to be able to feel clean and safe, and to make choices and feel respected. A recent study by Collier in 2020 in an acute hospital setting really evidenced how fundamental care is driven by a real team approach, not just nurses, a whole team approach, and a real philosophy of care, strong philosophy of care, and what the important essential elements, fundamentals of care are for people with cognitive impairment and people with dementia. There is actually an international learning collaborative, an international voice of fundamentals of care, and they work on ensuring people are aware of respecting and focusing on a person's essential needs. And these needs are met by developing a positive and trusting relationship with the person being cared for, as well as the family carers. Some of the resources that we may have in our settings, wherever we may be working, are really important to draw upon in terms of managing and supporting distress behaviours. For myself here locally in the trust I work within, we have many lovely initiatives which I'm really proud of. Um, I will talk about Pets as Therapy first of all. So we have a charity called Pets as Therapy who come into the hospital, who are volunteers, and I go around with them on a twice weekly basis. And we visit all of our wards, particularly focusing on people with dementia. And seeing the value of that is just heartwarming every time they visit. Many, many wonderful examples of Pets as Therapy. So do reach out to them and see if they can come to your area. We have volunteers for Namaste and Compassionate Care, and we are developing the role of the Dementia Ambassador currently. Our chaplaincy team are a really wonderful resource here. They are really passionate about supporting people with dementia, and we share referrals. So it's really important we meet person with dementia spiritual needs, and they often can support with emotional distress too. Time in nature. I've seen many of our patients that have just been quite overwhelmed by the hospital ward, and taking them outside has really supported managing those symptoms of distress behaviour. And we are currently going through a process where we're developing a dementia sensory garden. So hoping that's going to progress quite soon and we can continue to take people outside. But one of the things that is really growing within our organisation and our local hospice is our Namaste Care project. In 2020, I worked really closely with St Clair's Hospice for Namaste Care project, and they had some funding to set up a project which was to educate and support paid and unpaid family carers and professionals in supporting people with advanced dementia through Namaste Care. Of course, in 2020, the pandemic arrived and the training then went online, and we continued to drive those sessions forward. And now those sessions are face to face in our local hospice and in our hospital here. Namaste literally means it's a Hindi greeting which means to honour the spirit within. And when applied to people with dementia, it inspires us to look beyond the dementia and the care for the person inside. And if you are interested in learning more about that, please have a look at the work of Joyce Simard, who was an occupational therapist who developed the idea of Namaste. And it uses the five senses to really engage and connect with the person with dementia through touch, sight, taste, smell, and hearing. Um, and for me here in the hospital setting, it's also about a compassionate approach to nursing care. So if you are providing personal care for the person with dementia and they may be distressed, think about what you can do differently to enable you to deliver that care and to reduce that distress. It may be putting on some music, it may be different hand touch, it may be using different smells, it may just be coming back at a different time. But Namaste is advancing in the scientific evidence around it as well. And there's also a video which there is a link to there. So how we can help all of this, all the things I've discussed. So ensure that patients' hearing aids and glasses are turned on and they have access to them and they're clean. Ask family to bring in familiar objects, things that are important from home. Maybe it might be a blanket from the bed. It might be a soft toy or a doll, a baby doll. Um, Making sure that we have a completed This Is Me or an alternative document to that. Maybe providing a notebook or paper so we can write down messages, but of course making sure person with dementia can understand what we've written or can read or can see if they need their glasses. Talking to the person, reading to them, providing emotional support, really making sure we utilize the one to, if we have a one-to-one or if we have a mental health nurse supporting the person with dementia. So that's a real opportunity to really provide that holistic care. Consider using a behavior monitoring chart, but really carefully using the appropriate terms that we use. Thinking about the term aggression and how we can word that differently, distressed reactions, distressed behavior, and the meaning behind the behavior. Assess and treat delirium. Um, Working towards improving relationships with family carers, making sure our trust supports open visiting from our family carers, and please also remember the person with dementia's spiritual needs. Just some useful resources to finish with. The Sign Guidelines for Delirium, which came out in 2019. Antipsychotic Prescribing Guidance and Distress Behaviour Toolkit for NHS England, which came out in 2020. And the NICE Guidance for Delirium has recently been updated in 2023. And thank you for listening, and I'm happy to answer any questions.